don't think so. Okay. It is this patient has subjective shortness of breath with good oxygenation, clear lungs, and a deep breathing patterns punctuated by audible sighs. In addition, she has paresthesia of her hands that presented during a time of significant stress. This is consistent with hyperventilation syndrome, a condition of exclusion of characterized by intermittent episodes of hyperventilation without any obvious cardiac or pulmonary etiology. Manifestation include manifestation develop when alveolar minute ventilation increases enough to decrease the PaCO2. In some patients, can be this can be tachypnea, increase in respiratory rate. However, the respiratory rate may be near normal if the depth of the breathing is significantly increased tidal volume, as in this patient, deep breath size. Neurologic symptoms including paresthesia, headache, lightheadedness, carpopedal spasm are often present, may be related to cerebral vasoconstriction or alkalosis induced hypocalcemia and hypophosphatemia. Education and reassurance are the key components of treatment. Patients should be taught abdominal on diaphragmatic breathing, a retraining maneuver that involves trying to keep the chest still. These maneuvers generally take some practice but resolves most episodes. If the episode does not improve with breathing retraining, a small dose, not a high dose, of short-acting benzos is appropriate second-line therapy. Breathing into a bag was previously recommended to improve hypocarbia by rebreathing carbon dioxide. However, this can result in hypoxia and therefore should not be done. Okay. So looks like lung abscess. There is air fluid level. Yes, he has fever. Look at high fever, 103. Uh, and he has unstable housing. So remains fever. He has a cough and air fluid level looks like an abscess, lung abscess. And these abscess due to like aspiration, as he is staying in the slum, like in the shelter, and taking alcohol No, no. Due to anaerobic organism engulfment. Okay. Oh, so these patients' alcohol use, foul-smelling sputum, fever, leukocytosis, and cavitary infiltrate with air fluid level likely indicates lung abscess. Most cases are caused by aspiration of the oropharyngeal anaerobic bacteria, peptid streptococcus fusobacterium. In the setting of dysphagia or impaired consciousness due to alcohol abuse or seizure, those with poor dentition, gingival disease are at greatest risk. Because anaerobic bacteria grow slowly, generally arise uh, manifestation generally arise over 1 to 2 weeks. Common symptoms include fever, night sweat, weight loss, cough with foul smelling sputum. Although the mechanism is unclear, pulmonary infection, pneumonia, lung abscess, and malignancies are often cause mild hyponatremia due to syndrome of inappropriate SIADH. Chest X-ray and CT scan typically reveal cavitary infiltrate, often with air fluid level in the superior lower lobe or posterior upper lobes, sections that are dependent with recumbency. Anaerobic bacteria are difficult to isolate on culture, therefore patients with suspicious symptoms generally receive empiric antibiotics with an agent that has good pulmonary penetration and efficacy against obligate and facultative anaerobe. Ampicillin sulbactam is considered first-line drug therapy. Clindamycin is reserved for those with beta-lactam allergy due to high-risk subsequent Clostridioides, formerly Clostridium difficile infection. A prolonged course is indicated. Surgical intervention, pneumonectomy, lobectomy may be required in the rare case that do not improve with antibiotic therapy. Yes, pulmonary TB can cause fever, night sweat, and cavitary lung lesion. However, symptoms typically occur over several weeks or months, and air fluid levels seen in 20% cases of pulmonary TB are most common with lung abscess and are marked leukocytosis and foul-smelling sputum are more suggestive. Foul-smelling sputum are more suggestive of lung abscess. Okay. Yes. He's on ventilation, isn't it? And now everything is in normal level. Like PEEP is low and pH is good, PCO2 is normal, PO2 is normal. If so, we need to do some trials, then we should. Okay, so mechanical ventilation with intubation is associated with number of serious complications, pneumonia, pulmonary barotrauma. There is a duration should be minimized as much as possible. The initial criteria for extubation readiness include pH more than 7.25, adequate oxygenation, PaO2 more, 60 or more than 60 millimeter of mercury or minimal support, FiO2 is less than 40%, and PEEP is less or equal 5 centimeter of water, and intake inspiratory effort and sufficient mental alertness to protect the airways. Because there is a short-term risk of recurrent respiratory failure requiring reintubation, most patients who meet the above criteria should undergo spontaneous breathing trial to help confirm readiness for extubation. During an SVT, patient remains intubated but ventilatory support is turned off, allowing patient to breathe on their own for a short period of time, 1 to 2 hours. This patient is ready for a SVT spontaneous breathing trial as he is alert and following commands and has no normal arterial blood gas on minimal ventilator setting. Patients who maintain normal AVG parameters throughout the SVT are good candidates for successful extubation. So criteria is pH more than 7.5, adequate oxygenation, PaO2 is more than 60 on minimal support, and FiO2 is less than 40%, and PP is less or equal 5. Okay. Patient who maintain normal okay. Candidacy for successful extubation may be further assessed during an SVT using a rapid shallow breathing index RSBI, which is calculated by respiratory rate divided by tidal volume. Patients with high RSBI more than 105 are breathing fast and shallow and are unlikely to do well without continued ventilator support. Okay. Okay. When tidal volume is delivered to the ventilator, when tidal volume is delivered to the ventilator, the resultant pressurization of the lungs has two components. Pressure generated due to friction as a tidal breath flows through conductive airways endotracheal tube to the terminal bronchiole called resistive pressure and occurs during flow. An increase in pressure indicates a problem with increased airway resistance, such as mucus plugging or bronchospasm. Patients, a pressure needed to distend the lung by a given tidal volume. Pressure needed to distend the lung by a given tidal volume is called elastic pressure. An increase in this pressure indicates a problem with decreased respiratory system compliance such as pulmonary edema and abdominal compartment syndrome. These two pressure components are constantly summed together through the respiratory cycle. Total pressure equal to resistive plus is elastic pressure. However, they can be separated by pausing the ventilator momentarily after the tidal volume is delivered. The inspiratory holds maneuver. The inspiratory hold maneuver eliminates flow. Resistive component is zero, isolating the elastic component. The resulting flat segment in the pressure tracing. The resulting flat segment, the pressure tracing is called plateau pressure and reflects elastic pressure. The inspiratory hold maneuver localizes the problem when mechanical ventilation become difficult. When mechanical ventilation become difficult, the inspiratory hold actually localizes the problem. High pressure alarm. If the plateau if the plateau pressure is normal, if the plateau or elastic pressure is normal, the culprit is increased airway resistance, that is bronchospasm. If the plateau pressure, if the plateau pressure is elevated, if the plateau pressure is normal, that means increased airway resistance. If the plateau pressure is elevated, the culprit is decreased compliance, decreased respiratory compliance, that is pulmonary edema. Therefore, modern ventilators often diagnose dig insight into the patient respiratory physiology, serving as powerful extension of the physical examination. Okay. Total airway resistance is captured in the difference between the peak pressure resistive plus elastic and the plateau pressure elastic only. And there is zero upper airway resistance, tongue, oropharynx, supplements tongue, oropharynx, supraglottis in intubation patient because these structures are completely bypassed the endotracheal tube. Okay, yes. Okay, look at the uh, first normal response. When you are unable to like ventilate, like you are trying to ventilate the patient, but you are unable to do that, then you need to do this thing like inspiratory hold. If inspiratory hold, if look at the if plateau is higher, the two things like plateau and another is peak, and plateau. If plateau is higher, if plateau is higher, that then you have to think that it is respiratory compliance. Like I remember p r, like if problem in the plateau, then respiratory problem. And if problem in the, like if peak is higher, like high peak, both both has high peak, but it is all related to the plateau. If plateau is higher, then respiratory problem. If plateau is normal, then it is airway problem. uh, if uh, if plateau is higher, then decreased respiratory compliance, that means uh, PAP, like PAP test, pulmonary edema, abdominal compartment syndrome, and pneumothorax. And if normal plateau, then BBM, like biting the endotracheal tube, bronchospasm, and mucus plug. I know you don't haven't got it clearly because I do not know these things very well. This is related to critical medicine. Yes, yes. What is your diagnosis? Yes. Okay, intermittent respiratory symptom. Look at the box first. Intermittent respiratory symptom. If there is cough, dyspnea, wheezing, chest tightness, do a spirometry. If FEV1 by FVC ratio is less than 70%, inhale bronchodilator like SABA. If it is reversible, as I confirm it is non-reversible, then it is COPD. Spirometry, if spirometry is normal, but you are thinking asthma, give methacholine challenge test or methacholine bronchoprovocation test. If there is bronchoconstriction or bronchoconstriction, if there is bronchoconstriction, then it is positive asthma possible, negative asthma unlikely. Think about congestive heart failure, pulmonary hypertension, and vocal cord dysfunction. And like reversible means like uh, you are giving bronchodilator, and if FEV1 is 12% increase or 200 ml increase, FEV1 by FBC with post bronchodilator, that means it is asthma. Okay. This former smoker has episodic dyspnea, wheezing, cough, pulmonary function testing shows a reversible airflow obstruction, FEV1 by FBC less than 70%, with positive bronchodilator response more than 12% increase in FEV1 by FVC. The combination of her symptoms and spirometry is diagnostic Although asthma is typically diagnosed in younger individuals, a significant minority are diagnosed later in life. Adult onset asthma is characterized by a different immunophenotype with a greater airway remodeling. Patients have positive bronchodilator response. FEV1 by FVC ratio may not increase more than 70%. Distinguishes asthma from COPD is a common clinical scenario, particularly adult ever smokers. Both diseases may show airflow obstruction, but patients with COPD have no bronchodilator responsiveness. Emphysematous COPD Emphysematous COPD is association with decreased DLCO due to protease-induced tissue destruction, leading to loss of alveolar surface area. Okay, next. What are the common infection happens in patients with cystic fibrosis? Staph, yes. MRSA, yes. Okay. Pulmonary disease is the most common cause of morbidity and mortality in patients with cystic fibrosis. Defected mucociliary clearance, inspissated secretions, permits accumulation of debris and bacteria in the airway, resulting in recurrent sinopulmonary infection. This patient has severe acute pulmonary exacerbation as seen hypoxia and respiratory distress, nasal flaring, retraction, grunting. In young children, cystic fibrosis is the most common pathogenic organism, Staph aureus, especially in the setting of concurrent influenza infection. Given the history of recurrent hospitalization and skin abscesses, this patient has also increased risk of MRSA. MRSA colonization and infection, therefore, vancomycin is the appropriate antibiotic of choice for staphylococcal coverage. It should be administered immediately and intravenously in patients with severe pneumonia. Pseudomonas aeruginosa is the most common pathogen In older patient with cystic fibrosis, it should be covered empirically. In young children, as in this patient who is receiving cefepime. The fourth generation cephalosporin, however, has no activity against MRSA. Okay. Okay. This patient with cough, dyspnea, leukocytosis, and pulmonary infiltrate has recurrent community-acquired pneumonia. However, recurrent community-acquired pneumonia can be caused by a wide range of underlying bronchial, immune, and inflammatory conditions. The most likely cause in this patient is recurrent bacterial aspiration pneumonia due to advanced Parkinson disease. Patients with advanced Parkinson disease are at very high risk of aspiration due to difficulty forming a food bolus from lingual bradykinesia, impaired coordination of the muscle involved in swallowing due to autonomic dysfunction, and impaired cough reflex. As the disease progress, swallowing evaluation are generally required so that medications to diet, thicken liquids, and eating position, chin lift, swallow, thickened liquids, and eating position, chin lift can be made to reduce aspiration risk. Swallowing evaluation test the reflex action of the oral and the pharyngeal muscle, include observation of patient as they ingest liquids or solids of different consistencies. Those with signs of impairment, coughing while swallowing, often require additional evaluation, video fluoroscopy, modified barium swallow. Okay. What is your diagnosis? Okay, look at the labs: hypotension, sorry, hyponatremia, hyperkalemia, low glucose, eosinophil count. It is the TB, a primary adrenal insufficiency due to TB. Okay, primary adrenal insufficiency due to TB, tuberculosis. Okay, this patient has multiple finding consistent with primary adrenal insufficiency. Although autoimmune adrenalitis is the common etiology, disseminated chronic infection TB histoplasmosis can also cause the disorder. This patient's evidence of primary adrenal insufficiency combined with fever, pulmonary airspace disease, daily cough with lymphadenopathy, and prior residence a tuberculosis endemic region more than 30%. Global tuberculosis burden in Southeast Asia suggests miliary tuberculosis. Primary adrenal insufficiency involves the destruction of all three layers of the adrenal cortex. Lightheadedness and orthostasis, as seen in this patient, are due to reduced aldosterone causing renal sodium wasting, weight loss, hypovolemia with accompanying hyponatremia, antidiuretic hormone stimulation, and hyperkalemia. Renal potassium retention, reduced cortisol production contributes to hypotension, causes hypoglycemia. It can also cause peripheral eosinophilia. Non-specific findings sometimes seen in patients with adrenal insufficiency, as cortisol normally facilitates eosinophil migration from bloodstream into the tissue. Tuberculous adrenalitis due to extrapulmonary hematogenous spread is the second common cause of adrenal insufficiency. Worldwide anti-TB therapy rarely improves adrenal function, as seen in this, as the infection often causes irreversible destruction. Okay. This respiratory acidosis is due to drugs, isn't it? He is on naloxone. Single dose of naloxone, opioid, maybe, or other cause. That one due to like spinal cord deformity, like spinal cord problem. Like think decreased respiratory neuromuscular function. Neuromuscular disorder like myasthenia. It is not myasthenia. Then why he is on naloxone? Wait, one thing, look at the stem. He has a generalized anxiety disorder and major depression. So he is on maybe on sedative. That makes sense. Probably we are jumping A and C. Okay, pick one. Okay. Okay, look at here. Like decrease respiratory neuromuscular function. I am against it because it may be like some serious spinal cord problem, like maybe ALS or myasthenia fits with uh, severe decreased respiratory function, isn't it? So it is not myasthenia. Okay, look at the box first. Decreased central respiratory drive. It may be decreased central respiratory drive. It may be due to drugs like opioid or benzos or CNS trauma, stroke, encephalitis. Decreased respiratory neuromuscular function, spinal cord lesion, ALS, and myasthenia gravis. Decreased thoracic cage and pleural function. Decreased thoracic cage or pleural function. It may be due to obesity, hyperventilation syndrome, pneumothorax, rib fracture, or flailles. Airway obstruction like obstructive sleep apnea, upper airway, COPD, and pulmonary disease, lower airway, and impaired gas section like cardiogenic pulmonary edema and ILD. This patient has respiratory acidosis evidenced by pH more than 7 point, pH less than 7.35 and increased PaCO2 is more than 40 millimeter of mercury on arterial blood gas analysis. In addition, she has hypoxia, low PaO2, and decreased respiration consistent with hypoventilation. In this unresponsive patient with an otherwise unremarkable physical examination, this presentation is consistent with decreased central respiratory drive, likely due to an overdose. Likely due to an overdose, her pupil are normal in size and on naloxone opioid. Pupil are normal in size and naloxone opioid antagonist had no effect. Thus raises suspicion for benzodiazepine toxicity, possibly in combination with alcohol. Central respiratory center in the brainstem. Central respiratory centrum in the brainstem. normally regulate respiration based on input from a wide range of the central respiratory wide range from wide range of central and peripheral sources. Chemoreceptor volitional pathways. Benzodiazepine bind to the GABA receptor and increase the inhibitory effect. Benzodiazepine binds with the GABA receptor and increase the inhibitory effects of GABA in the CNS in case of severe overdose. In case of severe overdose, these can depress the central respiratory drive. This effect is potentiated by alcohol, a common co-ingestant. Management of patients with acute benzodiazepine intoxication should first involve the protection of the airway, ventilatory support as needed. Flumazenil, a non-specific competitive antagonist, is sometimes given as a reversal agent. It does not consistently it does not consistently reverse respiratory depression and can potentiate seizure in patient who has developed tolerance to benzodiazepine. Okay, is it hereditary angioedema? Like look, symptoms worsen after she takes over the counter analgesic. And if you think about analgesic actually blocks cyclohexinase pathway. Uh, Leukotrienes, yes. It is aspirin, AERD, aspirin exacerbated respiratory disease. It is not hereditary angioedema. In hereditary angioedema, bradykinin is the culprit. Yes, this patient is most common. This patient's presentation is most consistent with aspirin exacerbated respiratory disease, a non-immunologic reaction to aspirin or other NSAIDs Aspirin exacerbated respiratory disease should be suspected when on the SAMTER triad. Chronic rhinosinusitis, chronic rhinosinusitis, and NSAID-induced respiratory reaction, worsening symptoms after over-the-counter analgesic. Okay, aspirin exacerbated respiratory disease involves increased production of pro-inflammatory leukotrienes, decreased production of anti-inflammatory prostaglandin. NSAID inhibits cyclogenase arm of the arachidonic acid pathway and block prostaglandin synthesis, shunting it toward the leukotriene production arm. Aspirin exacerbated respiratory distress symptoms are due to these leukotriene excess and mimic asthma or rhinosinusitis flares. Patient may not always relate the symptoms to NSAID use, especially if they are taken habitually. Some patients may exhibit more dramatic symptoms, including facial flushing, arterial eruption, angioedema, and anaphylactic reaction, occurring within 30 minutes to 3 hours after NSAID injection. Unlike anaphylactic reaction, these pseudoallergenic reactions are not IgE mediated. Treatment include avoidance of NSAID. If NSAIDs are absolutely required, desensitization is sometimes necessary. Leukotriene inhibitor, pathway inhibitor, Xylute or montelukast can also improve the respiratory and nasal symptoms. Okay. Anti-neutrophil cytoplasmic antibodies. Anti-neutrophil cytoplasmic antibodies are associated with eosinophilic granulomatosis with polyangiitis, which often presents with prodromal asthma and nasal polyposis before the onset of overt systemic vasculitis. However, the history of NSAID sensitivity is more strongly suggestive of AERD. IgE is the primary upstream player in type 1 hypersensitivity reactions such as anaphylaxis, angioedema, extrinsic allergic asthma, dust mites, pollen, and allergic rhinitis and conjunctivitis. However, it is not involved in pathogenesis of AERD. Okay, this patient developed acute hypoxemic respiratory failure, hypoxia, tachypnea, with bilateral pulmonary infiltrate during blood transfusion. His normal BNP concentration, normal cardiac size, lack of jugular venous distension make acute cardiogenic pulmonary edema from transfusion-associated circulatory overload unlikely. Therefore, the most likely diagnosis is transfusion-related acute lung injury. TRALI is a rare but life-threatening complication of blood production transfusion marked by massive release of cytokine, reactive oxygen species, and other inflammatory mediators from neutrophil is the primary vasculature in response to transfused blood component. Management manifestation begin within a few hours of transfusion. Transfusion initiation include acute inflammatory pulmonary edema with hypoxia, tachypnea, and bilateral pulmonary infiltrate fever, tachycardia, hypotension are common. Treatment includes immediate cessation of the transfusion and ventilatory support. Some patients recover within 24 to 48 hours, but 50% die. Okay, yes. Trali, taco both can cause acute dyspnea, both can cause crackle rals, and taco comes with S3. Chest X-ray, diffuse bilateral infiltrate, blood pressure low uh, to normal is Trali, and taco is normal to high. JVP distended in case of taco, as it is volume overload, so JVP is raised and BNP is high in taco, but ejection fraction is decreased in taco. It is normal in Trali. In Trali, BNP ejection fraction is normal, but in taco, BNP is high, ejection fraction is low. Okay. Is it bronchial carcinoid? Mhm. This patient has two episodes of right lower lobe pneumonia over a short time frame. Both infectious, both infections symptomatically improved with antibiotic therapy, but she continues to have wheezing and pulmonary infiltrate in that region. Recurrent pneumonia in same anatomic portion of the lung is usually structural lesion inside the foreign body or around the proximal bronchus. Obstruction of the bronchus impairs clearance of fluid from the alveoli, leading to microbial aggregation and high-risk infection. Although bronchial carcinoid tumor accounts 1 to 2% of lung malignancy, they are leading cause of lung cancer in adolescent and young adults, particularly in those who do not smoke. Tumors are tumors are typically slow growing and round and generally form in the proximal airway. They can present with wheezing, dyspnea, cough due to bronchial obstruction, or hemoptysis due to tumor bleeding from the hypervascularity. Compared with gastrointestinal carcinoid tumor, bronchial carcinoid tumors produce far less serotonin or vasoactive amines and do not often cause carcinoid syndrome. Recurrent pneumonia can be seen with systemic disorder, immunodeficiency, cystic fibrosis. However, patients with systemic causes of recurrent pneumonia have pneumonia in different regions and infection in other portion of the respiratory tract, sinusitis. Is it pulmonary function test? Okay. This patient has chronic cough more than 8 weeks. Chronic cough include upper airway cough syndrome, postnatal drip, GERD, and asthma. Other causes are ACE inhibitors, airway disease, non-asthmatic eosinophilic bronchitis, chronic bronchitis, bronchiectasis, malignancy, pulmonary parenchymal disease, lung abscess, interstitial lung disease. This patient has chronic cough that worsens overnight and did not improve with antihistamine therapy. Some patients should be suspected of having asthma and therefore should be evaluated with pulmonary function test to assess some bronchodilatory response. Imidacloprid challenge test can be performed if bronchodilator is unresponsive, not nocturnal or early morning peak expiratory flow rate measurements can be used to diagnose patients with only nocturnal symptoms. An alternate approach is to treat empirically 2 to 4 weeks. Inhale glucocorticoid. If the cough improves, the diagnosis of the asthma can be made. Okay.